Thanks, Dr. Raymond. Hi. So the question was what to do with a patient who's had a recent event or a previous event and investigations show a complete carotid occlusion. Well, once the carotid is completely occluded, and particularly if it's more than a day or two old, in fact, there's no intervention that you can do most of the time. The clot propagates up to the skull base and it no longer becomes a surgical issue. Most events that happen on the same side as a completely occluded carotid occur around the time of occlusion, and there's actually quite a high early event rate. So if you have a TIA today, you do an investigation, you find that the carotid is completely occluded. Chances are that that carotid has just occluded. And so those patients do need aggressive antithrombotic therapy, but for the most part they're not surgical candidates. And once they survive that spell, if they did not suffer a disabling stroke, often the stroke risk related to that carotid occlusion then falls off quite rapidly and it becomes a stable situation. So for the most part it's not interventional management, but it is good ongoing stroke prevention with antiplatelet therapy, control of blood pressure, lipid lowering, and all the other risk factor management.
We use TPA, but can we use TNK for stroke, and why if we cannot?
Okay, good question. So you have TPA for acute stroke, and the question is, can you use another thrombolytic agent, TNK, for stroke? The evidence right now is for TPA because we understand the dosing and the benefits and the hemorrhagic risks. There has been some early work done with TNK, but we still don't know the effective dose, and we still don't know the relative risks and benefits and hemorrhagic risks. So while it's a promising agent, it's not approved for the use in stroke. So I would recommend just stay with TPA as per the usual guidelines. That's the standard of care. Some hospitals don't routinely stock TPA for cardiac indications anymore, but they do have to stock it for the stroke indication.
My question, Phil, is about how we are, as hospitalists, we're managing lots of non-STEMIs and ACSs, and it seems like the approach to the acute stroke appears different than the acute ACS. Why is there a difference in the anticoagulant approach, i.e. no low molecular weight, etc.? Thanks.
Sure. So thank you. That's actually a really good question. So with acute MI, acute coronary syndromes, of course, there are multiple antithrombotic strategies: aspirin, Plavix, low molecular weight heparin, and so on. The issue with stroke, of course, is quite different. The brain is a different organ, and the major risk of a lot of anticoagulant therapy is, in fact, intracerebral hemorrhage. And so, for the most part, we do not use anticoagulants, heparin or low molecular weight heparin, in therapeutic doses to try and treat the acute stroke. We do use them in DVT prophylaxis doses to prevent the DVT and pulmonary emboli, but there's really no proven benefit for the use of anticoagulants in acute ischemic stroke in unselected cases. There are occasional situations with interluminal thrombus where there's a biologic rationale for using an anticoagulant, but there's really no overall proven benefit. So for acute stroke, really the only evidence right now for an antithrombotic is for low molecular weight heparin or unfractionated heparin in DVT prophylactic doses and an antiplatelet agent such as aspirin.
Hi, I really enjoyed your presentation, and I have two questions. Could you comment on the use of statins acutely in stroke, kind of along the same lines as Wayne's question about managing ACS? And the other question I have is, what recommendations would you give to somebody who has had a stroke or a TIA on an appropriate dose of an antithrombotic agent already, and who doesn't seem to be in atrial fibrillation or have some other reason for systemic anticoagulation? Should you add a different, clopidogrel, or should you just change to Coumadin?
Okay, so the first question, thank you. The first question was the role of statins in acute stroke. So statins have been, of course, evaluated and studied in the acute coronary syndromes. They've not been actually studied in the management of acute ischemic stroke. So we really don't have any clinical trial evidence on the benefits of statins in acute stroke. I think it's unlikely that they're going to be harmful. We do think that statins is part of long-term stroke prevention in patients who've had a TIA or stroke. And if you look at the current iteration of the Canadian lipid guidelines that came out about a month ago, the target LDL for patients who've had a TIA or stroke is less than 2 for the most part. But we simply don't have data for the immediate use of statins in acute stroke, so it's really not part of our usual guideline. The second, but they should be on it before they leave hospital. The second question was the selection of antithrombotic therapy, and I presume this was for secondary stroke prevention. So if they've had an event while on an antiplatelet agent, that's the most common scenario that we get. I think there's 3 things that I usually focus on. One is, were they truly on it? One of the failures of aspirin is the failure to take aspirin. So you should actually question them as to whether they were on an agent and taking it actively prior to the stroke. The second thing is, if they've had an event while taking an antiplatelet agent, then you want to investigate the patient to make sure you understand the mechanism. Aspirin or clopidogrel or ASA dipyridamol are great drugs, but they may not address the issue. If they need their carotid artery fixed, that's the treatment. If they have a cardiac source of embolus, then they're on an antiplatelet agent when they should be on an anticoagulant. So the second thing I do is make sure that I understand what their stroke mechanism is. And then finally, you get the situation where they had an event, they were actually taking, say, aspirin or another agent. And then, providing I understand the mechanism, I usually then will switch antiplatelet agents. If they had an event on aspirin, there's a lot of reasons for so-called aspirin failure, but there are other agents, and I'll often switch to one of the other medications. And in British Columbia, for reasons of reimbursement for the patients, it's usually clopidogrel. Maybe while I've got the mic for just 1 second, I'll put in a shameless plug for the stroke prevention clinics that have been set up around the province through the BC Stroke Strategy and the efforts of the Heart and Stroke Foundation. This is one way in which family physicians can get patients to be seen in an expedited fashion. We have same-day access in our stroke prevention clinic and in others, same-day access to the critical imaging. And so if you're a family doc working in the communities, then you can access the stroke prevention clinic. And within the BC Stroke Strategy, there is information on the locations, the phone numbers, the fax numbers of the stroke prevention clinics in Fraser Health and in Vancouver Coastal and the Inland and in Victoria. So I would really encourage you to utilize these resources. We love to see patients with TIAs and recent symptoms, and we'll try and do our best to accommodate them. And the second shameless plug I'm going to put in is that we have a stroke hot pager here at VGH, the 604-707-3030, or you go through BC Bedline. One of our stroke neurologists is on call. We do receive calls from around the province, and we're pleased to discuss. That's designed for acute management questions of a TIA or stroke patient that might be in your emergency department, and we're pleased to try and accommodate you on those questions.
Great. Thank you very much.
Sorry. I was asked to repeat the phone number, 604-707-3030.
That's great. Thank you very much, Phil. So once again, just in closing, we'd like to thank Dr. Warnerbolt and Dr. Teal and all the participating sites and the individuals at those sites. For physicians, remember to sign your attendance form with your name and email so we can send you a CME certificate. And again, we'd like to suggest if anybody has any other questions, send them to info@BC Stroke Strategy. And what else we've got here? So this presentation also is on the BC Stroke Strategy website, and it has been video recorded, and we'll have that up on the website probably within a week to 10 days. And then the last point is that we are going to be having another telelearning series in March, and it will again feature Dr. Teal, and we've come up with a preliminary title of Demystifying TPA. So stay tuned for that, and we'll send out an announcement on that as well. So thanks again, everybody. Appreciate you participating, and have a great day.